This is part 5 of our section on shock. These are the shock drugs. Okay, so you can see here I have a picture of several different types of drugs, and you can see if they're working on alpha 1, alpha 2, beta 1, beta 2, and this becomes central to our discussion today. The goal of this lecture and why it's in part 5 is because we did speak about hypovolemic shock in part 4, and there weren't a ton of medications that we would give in hypovolemic shock, though there are some vasoactive meds we may have done to support the heart. But in general, in the other shocks, we give meds very often to help those people recover. So remember, a hypovolemic shock is really stopping the process of why the fluid loss is occurring and then replacing it. So this is just a little bit different here as we go into these meds. Okay, so what are vasoactive drugs? So vasoactive drugs are vasodilators and vasoconstrictors. Things like morphine, nitroglycerin, calcium channel blockers, they all dilate. In a hypotension state, we tend to use vasoconstrictors. But in cardiogenic shock, when you need to give some support and relief to the workload of the heart, we use the dilators. So these meds are given in critical care areas where the RN does have a role in titrations of the medications to stay within certain parameters, usually based on the MAP or some other criteria, but MAP is the most common. These are all high alert drugs because mistakes can be deadly. The response to the drugs are very quick and overcorrection can occur. And this is why we make very small incremental dose adjustments and we wean up and off. So remember to review the patho of alpha 1 and beta 1 and beta 2. So alpha 1 constricts the blood vessels, beta 1 acts in the heart in contractility, and beta 2 works to cause bronchodilation. So the vasopressors, if you look at my little picture here, we have the vasopressors stimulating smooth muscle contraction that causes vasoconstriction, which can help increase the blood pressure. And then inotropic medications, they increase the force of the contraction of the myocardial muscle. And so positive inotropes can also increase the blood pressure, which the end goal of any of these medications is to increase perfusion. So this is just a little nod to the natural causes of vasodilation in our body. So some things that can occur to cause vasodilation, of course, is our low oxygen and high carbon dioxide, our pH. As we go into anaerobic metabolism and lactic acidosis, that can cause vasodilation. Gram-negative bacteria are very potent endotoxins that are created, and those can cause vasodilation. Cytokines like interleukin-1, a tumor necrosis factor, all of those can absolutely cause vasodilation. Nitrous oxide is intrinsic in all of us. However, if the enzyme is stimulated and we make more, then we would have more dilation. And then our prostaglandins are also dilators. So this is why, despite everything that we do as we're using vasoconstrictive drugs and doing everything we can to help the person in a shock state, we are attempting to overcome the body's natural dilation. Okay, so these are the main drugs that you need to know very well. Why is it important to know these drugs? Because you need to be aware of what medications you will be giving for different types of shock. So for example, if you have cardiogenic shock, then you want to use something that will decrease the afterload and increase contractility. So if you were to give them a vasopressor at this time, it could be deadly. So you need to look at the pathophysiology of the type of shock that you're dealing with, and then consider what medications, if any, are appropriate for them. So this is made out of your textbook, And again, this is not an all-inclusive list, but some exemplars and some different agents that are in each of the classes. So inotropic agents, they improve contractility, they increase stroke volume, and increase your cardiac output. But one of the problems is they can increase the oxygen demand of the heart. The vasodilators reduce preload, and they reduce afterload, and they reduce the oxygen demand of the heart, but they can cause hypotension. And the vasopressors cause vasoconstriction, which actually can increase afterload, increase your cardiac workload. And because of that, if we have too much vasoconstriction, we can compromise perfusion to some of our vital organs. Now, we're going to take a deep dive into some of the medications. So things to think about is that NCLEX does use the generic name, so make sure you know the generic name. I have provided both here for you, but it's a really good idea. So dobutamine is a good choice for those in cardiogenic shock because it causes less tachycardia. So it's also good for those in heart failure. It does increase contractility. But remember, if we increase the heart rate, it can cause more work on the heart. So this medication decreases systemic vascular resistance and our PAWP or PAWP. Some other things to think about dobutamine is that you need to give it via central line. Be on the lookout for tachydysrhythmias. So if you see one of these, then you are going to need to stop this infusion. And this medication is not to be administered with sodium bicarb. Okay, so we'll go on to the next medication, which is dopamine. Now, dopamine was the first-line vasopressor, but we found that it increased the heart rate at higher doses, can cause tachycardia. It's being replaced by other vasopressors, so you will still see this used. Remember, tachycardia is often an undesirable side effect because it increases the oxygen demand. So that's in your notes down below there I put for you. So dopamine causes different actions in different dosage. So dopaminergic, so that's 1 to 4 mics per kilogram per minute, is used to increase urine output. So for those folks who are slow to pick up the urine output, maybe post-op, the doctor may order this to help them kick those nephrons into gear. Okay. Once you increase the dopamine to that 5 to 10 micrograms per kilogram per minute rate, it starts to increase heart rate contractility. It starts to work on beta 1. And at the highest dose, this will increase systemic vascular resistance and bring up the blood pressure as it works on alpha 1. So the order that you receive will really depend on what the doctor or provider needs to correct. So dopamine can also not be given with bicarb and should be given by a central line. So for dopamine, I want to make sure you know to monitor your patient for peripheral vasoconstriction, because if you see signs of decreased perfusion in the extremities and the peripheral circulation and they're on dopamine, this can be the cause of it. All right, we'll move on to the vasodilators. So the exemplars I have here are nitroglycerin and nitroprusside. Milrinone is also a vasodilator. So nitroglycerin, often used for cardiogenic shock. Nitroglycerin, we also, people carry nitro around for acute coronary syndrome, for angina. So at a low dose, it decreases preload, and high doses reduces afterload. So basically, think about what's happening when we have cardiogenic shock is that we have a sick pump, and the body does try and sort of clamps down circulation with the sympathetic nervous system. And if you already have a weakened heart, it makes it harder to move that blood forward. So by causing some dilation, this is desirable because it decreases how much the heart has to work against moving that blood forward. So another vasodilator, believe it or not, is morphine. So nitroprusside, it's a very potent. It acts the same as nitro, but it can act in a couple of seconds. It's for immediate reduction of blood pressure in a hypertensive crisis until a longer acting medication can kind of kick into gear. The problem with nitroprusside is that it's metabolized in the red blood cells, and when it's broken down, it produces cyanide. So, given our person increased levels of cyanide is not desirable. The antidote to nitroprusside is something called amyl nitrate. It's not, again, nitroprusside's not being used that often, but it's a need to know medication. Um, so milrinone is also a vasodilator, but it's used to treat life-threatening heart failure. It is a positive inotrope, but not so much in the way of a chronotrope. So you would never give these vasodilators in circulatory shock because they are already vasodilated. These meds are generally used in life-threatening hypertensive emergencies and cardiogenic shock. All right, so the next medication we're going to discuss is norepinephrine. So norepinephrine does work on alpha 1 and beta 1. It is a very potent vasoconstrictor. So that means that it will cause contraction of the smooth muscles, and it can increase the blood pressure and cardiac output as a result of that. So remember, it's a vasopressor. Norepinephrine is the precursor to epinephrine or adrenaline in the body. Commercially, we know it as Levophed. So with this, because it is so potent, you need to monitor the person every 2 to 5 minutes. This drug may cause mottling. Central line is preferred for this one, and it should not be infused into a femoral artery with atherosclerosis. Though often started on the peripheral to get the pressure up to reestablish perfusion, this does need to move to central line, and in NCLEX land, we would want to have a central line for this. This is a great first line treatment and is the sole first line treatment for septic shock because it will increase everything the person needs in that distributive shock, which is, of course, the blood pressure and cardiac output. Also in line with the vasopressors is Neosynephrine or phenylephrine. So this is a pure alpha 1 adrenergic agonist. So what that means is that it affects the tone, not the heart. If norepinephrine is not working in septic shock, this is something that may be used. And yes, this is the same drug that's used for nasal congestion and to stop bleeding, because remember, it's a potent alpha 1 agonist. And for this one, because it works on vasoconstricting, you would also assess for mottling. Okay, so this is just another slide. I think that it can help you visual learners to sort of understand the different dosages and where the medications work. So for example, dopamine increased dosages shift to alpha 1, which causes increased vasoconstriction for tone. Note how potent the epinephrine is in a small dose, whereas dopamine and norepinephrine are different. Phenylephrine is a pure alpha agonist, so it does not affect beta 1, beta 2. The only one that has dopaminergic effects is dopamine. So again, this is something that you may want to take some time and look it over. All right, so the last medication that we're going to discuss under shock, and again, this is not an all-inclusive list. This is just some of the nursing information about them and using them in shock, is atropine. So atropine is an anticholinergic medication. It basically counteracts the parasympathetic nervous system, so the rest and digest. We use this medication in neurogenic shock. So if we have somebody who has a decreased heart rate because of the blocking of the sympathetic nervous system, as we see in neurogenic shock, then this is often a medication that would be used along with norepi, and it treats the bradycardia. So this is a medication that doesn't have a very long action, so it's usually used sort of as a bridge to something more permanent, whether that be something like surgical correction, stabilization of a fracture. Okay, but all right, guys, so this was a very short section on the shock medications. Thank you so much.